do that is having champions and having good examples. And I think one of the good places that's starting to happen within UC Davis is our pharmacy pilot with embedded pharmacists. And they're using for a number of, whether it's for diabetes, ADA guidelines, for coronary artery disease, the ACC, AHA guidelines, and for hypertension, JNC8. And we currently have two pharmacists that are engaged in 7 clinics, and their use of guidelines with the physicians in those practices and working with the physicians, I think, helps to share the idea that to be able to share care, you have to have some type of shared standards or shared recipe. And I know that sometimes people feel like cookbook medicine is the question, and people are sometimes intimidated or bothered by the idea. But to be able to practice in a team, you have to share something. So I think this is a great way of starting to shift culture. The other way is then providing that feedback and seeing the feedback often about how we're doing versus those measures that are establishing guidelines is really helpful. So we have created a monthly physician quality report that's both at the doc level, and now we're having the ability to provide it to the aggregated clinic and system level for A1C control per the ADA guidelines, LDL control, and we also now, because of some of the changes in how we approach cardiovascular risk, using statin prescribing, measuring that for patients with diabetes, as well as giving physicians their performance on blood pressure control. I think this is starting that culture change and being able to do that in a way that makes people feel like we're all in this together, that it's not a way that we're going to judge you. At first, people wanted to call it a report card, and we wanted to stay away from that idea, to say that it's really just a report. And I think that's the foundation for getting people to believe.
How transparently do you show that between others? That is, can everybody else see everybody else's?
Not yet, but we're moving towards it. We have a new report out of something we call our patient-centered medical home registry that shows all the docs on the same page across all the measures. And we're going to start with the practice managers and the local medical directors, and I think that would be the way to move to that. We've given that information on individual initiatives, where you can see everybody's performance, and Dr. Slapnick, our medical director of the Primary Care Network, calls that the horse race report, because we report them in bars to see how far people, the differences between folks. And we've done it for individual initiatives, but we haven't done it across the board, across a whole series of measures.
Nothing like peer pressure.
Yeah.
You don't want to be the last one.
Well, one other question, who's included in terms of patients then?
Sure.
Managed care patients?
We include all patients. We've been able to do this by an agreed upon one visit in 18 months is our attribution. And even that, establishing that is what your attribution would be, required some, socialization of the idea and culture change. Because everybody has a different idea about what that should be. Okay, so I'm going to talk briefly, give the introduction to tracking and coordinating care through our medical neighborhood, and then I'm going to turn it to Bridget for how we're doing that. So it's quiz time again. All right, so research from the University of Washington has demonstrated that a program utilizing a care manager for diabetes patients can do which of the following? A, improve depression symptoms, B, improve control of blood sugar, C, improve quality of life, D, lower costs, or E, all the above. So is there evidence that supports any of these? I should have put none of the above, too. I think I made it too easy. Everybody's logged in? Yeah, that was not a very hard question. An easy teacher, or a smart class. So we based the idea of that actually was studied at University of Washington. Wayne Caton was the person who kind of founded the model, and actually he just passed away this year. Wonderfully positive, kind of team-oriented person, and it was very clear why he developed this. It reflected, I think, his philosophy just about medicine. And he started this as a research program looking at diabetes and depression, and it has become their way of doing business in their primary care clinics, and they also then host people to come up and see how they do it. And as patients with diabetes and depression and some other chronic diseases actually in other programs, and they use a care manager, the primary care physician, they use an interdisciplinary team that includes a psychiatrist, And they really are hoping to help people become behaviorally activated. And that depression is a serious barrier to that they address. They use treat-to-target protocols, very similar to what pharmacists do, and a pharmacist is on their team. And they're basically, for both the medical conditions and the psychiatric conditions, doing that treat-to-target. And they do that by, after treatment, they do timely outreach after the initial evaluation and monitoring in between using standardized tools for monitoring like the PHQ-9. And the outcomes that they had significant A1C improvements, decreases of more than 0.5. Their systolic blood pressure was reduced by greater than, it was 5 to 10 millimeters, which, in aggregate is a decent reduction. They used SCL20 in the research, which is like a PHQ-9 type depression score. They also looked at kind of adjustments in treatment, that they had more adjustments to patients' medications than the control group. And they measured quality of life scores and had improved quality of life, which showed it wasn't just that it made us feel better about our measures, patients felt better. And finally, his model did have decreased costs, $600 per patient in their managed care patients, and $1,100 in their fee-for-service patients. So Bruce is going to talk about our team and how we learned from them.
So with the reduction in cost, was that primarily because inpatient costs are the highest driver? Was that what they did, that they prevent inpatient?
It was inpatient. There were decreased hospitalizations and ED visits.
The care coordination program, we've been up and running for about 3 years. And the team includes a primary care provider, the RN care manager, and the LCSW care manager, a pharmacist, and a psychiatrist. So we've been lucky enough, after learning at University of Washington the integral piece that the psychiatrists can provide, and we've been able to get percentages of a couple of psychiatrists that have become very integral to our process. And as I said before, all that team dips into the education as well, so we have a lot of crossover. We just physically moved into the same location 2-3 weeks ago now, and I think it's going to bode really well for us to be able to do more collaboration. So the care managers work telephonically with their patients, and the patients come into us either from a report, which I'll go into in a minute, or via PCP referral. And we give them guidelines, as the doctor's guidelines, as to who's appropriate to send over for care coordination and who probably not so much. We never say no to a patient, but we sometimes will circle back to a provider and sort of clarify what their goals were and how they thought we could really help that particular patient. The typical patient is one that has, as I said, multiple comorbidities, lots of times psychosocial problems or diagnoses, polypharmacy, elderly, lack of social support. That's sort of the picture of our patient. And the teams provide longitudinal support. As we go forward, we're learning that patients really might need some hand-holding down the road, even when we think they're okay. And we've learned that from our internal medicine medical director has sort of said, you return the patient to usual care, which we call usual care, meaning they've stabilized, but that patient then falls off the fence. There's a lot to be said with just a telephonic check-in even every month to say how are things going and how are your medications and those kinds of things. We're also looking right now at different levels of staff to provide some of that longitudinal support, but that's another story, I guess. So since 2012, we've outreached to over 23,000 patients, and we've engaged over 10,000. So just by that number, you can see that not everybody's ready to sign up to engage in care coordination. And some patients are, maybe desperately needing care coordination, but they're not ready to say yes. And so we don't give up on those patients. It's like Prochaska's model. It's different places on the readiness, and we'll continue to circle back. So the the care manager assesses the medical risks and comorbidities. This is actually the health navigator is going to be assessing these things, and will then assign the patient to a care manager. when the care manager's in the chart working with the patient, and again, it's all telephonic so far, the care manager is in the chart, they may notice some pretty obvious care gaps with that patient. For example, maybe they haven't had a mammogram in 5 years. So the care manager's in the chart, they have a relationship with that patient. It works very nicely for them to be able to say, I noticed you haven't had a mammogram, I can sign you up for that today, would you like to do that? And that's another way that we can enhance and support the care team. So the way the enrollment process works, and I'm just going to talk through this slide, is that we get, every 24 hours, we get a report. The report identifies patients that have been in the ED or the hospital over the last 24 hours. So our navigators will look at that report and identify by risk stratifying. And right now we're still doing it organically, meaning we're not doing a software program, although those do exist and we're looking at those. The navigator will assess all those things that we're talking about: polypharmacy, comorbidities, age, many patients that continue to miss their appointments. Those are patients that could probably use some support. Lots of different diagnoses, and when the patient has a behavior diagnosis, that's when we will bring them into our multidisciplinary team, which includes the nurse, the social worker, and the psychiatrist. And they'll review those patients. They'll review patients newly brought into that group over the last week. They meet every week for 2 hours, and they'll say what are the challenges and risks for this patient. The psychiatrist has been very, very helpful in supporting our care managers as to different ways to engage that patient and directions to go, as well as when they're reviewing the chart, they're looking at the notes and the prescriptions that the PCP has working on this patient. And what we noticed to be very effective is that the psychiatrist can reach back to the PCP and identify there might be a better or different psychiatric medication for that patient. And that works really well because the other thing that our psychiatrists do is they go out and meet with our primary care providers twice a year, what we call lunch and learns, and they go out and they build bridges and relationships with these PCPs so that when the PCP hears from the psychiatrist, it's a colleague and it's a very collaborative, supportive thing. And we've noticed that all of the PCPs make that prescription change right away, and it's the PCP that's ordering it, it's not the psychiatrist. So that's been a powerful thing we're doing.
Are they speaking about particular patients at that meeting with the psychiatrist?
Exactly.
So they bring in specific patients of that PCP and
Right.
may benefit from.
Right. We have teams, so we have the psychiatrist works with a social worker and a nurse, and they review maybe, I don't know, Linda, 4 or 5 patients that came in that week. Okay. So they review a lot of patients that have come in that week, and then they'll identify the meds and challenges. So, yeah. You have a question?
Yes. We know that depression is usually present with patients who have chronic medical conditions,
Right.
especially multiple chronic conditions. So do you have a standardized process of screening for depression, or is it just when somebody notice or suspect it?
Right.
Do you routinely?
So thank you. So if the patient has depression on their problem list, that's done. But we also know that it's not always identified. And all of our care managers are able and skilled in administering the PHQ-9. So they'll do that routinely via the phone. And then ideally we'll recheck the PHQ-9 in the next call or so. And we have seen a decrease in that.
So how often are the psychiatrists going on to meet with the PCPs?
So we have 14 primary care network clinics. I'm looking at it. And then we have our hospital-based clinics. And the psychiatrists go out to each of those sites twice a year. And whether we're going to continue to do that or we may shake it up and use them in a different way, we'll certainly keep them going out at least annually. I want to make sure we make the best use of these doctors. And each time the psychiatrists go out for the lunch and learn, obviously we bring lunch. So they tend to come. And not that they wouldn't come anyway, but And then we also are able to identify from the learners, from the providers, what is important to you, just like we do with patients. What would be helpful for you to learn? Because that's what they're going to talk about. And over time, we've noted that a lot of the PCPs come in with case studies that they really want to talk about, are challenging to them. So engaging patients is always a challenge. You can see from these numbers is that if a physician is referring a patient after talking to their patient, like, you know, Mrs. Smith, I think it would be really awesome for you to meet with one of our care managers to have a little help with your heart failure management. I'm going to have them call you. They'll call you within the next 5 days. How does that sound? Oh, okay, doctor, that's great. We get 76% of those patients that pick up the phone and talk to us. As opposed to the ED or the hospital report, those patients have been in the hospital, been in the ED, they're home, they're back to whatever their life is or was. And when we're calling them without a connection, and we're working on changing that, but so far without that connection, they're like, you know, I'm home, I'm good, no need, I'm good. We only engage 37% of those patients. So what we've learned from that is we need to have a face for that patient, and we're going to make sure that that starts to happen. The frequency of contact, either via phone or MyChart, is about 2 calls a month and then several MyChart messages. That said, as we go forward again, and we're reinventing this program, we know we need to see the sickest patients and a lot of the other patients for more hand-holding. Not that there's anything wrong with that, but we want to be able to see the sickest patients with our most skilled care managers. So that's where our energy is going to be going next. A couple of stories. So LW is a patient that was 52-year-old woman, had been in the hospital or emergency department 13 times over the last year. We got, exactly, whatever that was, yeah. So we got referred to work with that patient about five hospitalizations before. In other words, she continued to go back. We were calling, and it was a physician referral that the patient was like, no, I'm good, no, I can't, no. And at one point, our care manager asked if she could go and meet the patient at the clinic appointment. And we thought, you know, this is really an extraordinary patient. Let's try this. And so that she went out and she met the primary care provider and the patient and the brother, you know, the sister and the husband of this patient. And they all were in the room together, and it was like a huge aha right then. And the patient was able to identify with the care manager. This is not some voice on a phone, this is a person. She really wants to work with you. We found out that, so some of the diagnoses of this person were that she had progressive renal failure, diabetes, heart failure, those were the big ones. And she wasn't even, she was not able on her own to take her insulin, so she wasn't. And nor would she allow her husband, who was able and willing, to give her the insulin. So that was our first low-hanging fruit, is how about you let your husband give you your insulin shots? And the doctor's there, and it's a good idea, the patient's in the discussion. And bottom line, there were a lot of those little things that happened at that one tiny visit. And after that, she continued to talk on the phone to the care manager. And 6 months following that engagement, following that connection, the patient only had 1 hospitalization. So that was a made a difference, made everyone feel like they made a difference, the patient felt successful. It was just a win-win. Patient DL was a patient that was a very frequent caller via telephone advice or requesting to come into the cardiologist. She had multiple cardiac diagnoses, but really was not as unstable as you might think when you looked at her encounter numbers. So the cardiologist actually asked the PCP, because we only take referrals right now from PCPs, to refer that patient to us. And once that care manager reached out to that patient, the goal, frankly, was, and this was not extremely skilled. This was a call for the care manager to simply check in. How was your weight today? Did you check it? Are you watching your sodium? Do you need to talk about that again? Those kinds of things. And what happened in the long run was that those calls reduced in time, so that there was not as much there's not as much need for that patient to come in from the patient's perspective to the doctor, and thus access became improved for other patients.
Okay, so my job for the next part is to sort of try answering this question a little bit, and does it reduce costs? And this is a very difficult question to answer. Getting our cost information out is not easy, and so we enlisted the help of a fellow who was working for our hospital director to say, help us look at this. So we did we looked at a period of time, all the patients who came in over a 2-month period, and looked at their prior 6 months and the post 6 month after engagement with the care manager. And each of those patients had their own unique time frames, but then we aggregated what happened, and we were looking at inpatient hospitalizations and ED visits during that time. And when we trended these and looked at it, for the 139 patients analyzed, there was a 25% decrease in ED visits and 35% in inpatient encounters. So it was pretty good. Then we said, well, let's look at the sickest patients, like the people that Bridget was just mentioning, and then much bigger reductions, which makes sense as well. So, having this information, we really weren't able to actually pull out all the costs. I mean, we just actually have made the conversion with Epic to be able to now have our billing systems and our electronic medical record together. So we don't have the exact cost, but we worked with this analyst to sort of say, okay, well, if this were our average costs, what would the savings be, and how much does that compare to the cost of the program? And we were happy to hear that it was the cost avoidance, assuming that cost avoidance is completely good to the institution, and we're not fully capitated, but it really helps us with our capitated patients in terms from a cost savings standpoint. But the system is looking to value in the future, and that all payers will seek out value. It would be that the cost of administering the program could be realized through the savings in emergency room visits and hospitalizations. The limitations of looking at it this way, it was a short period. This was during probably one of the busier periods over the wintertime. Who knows whether the actual cost is the real cost. We actually had him, he was he was an MBA, so he ran a Monte Carlo simulation with different costs and all kinds of other things like that. And it actually still worked out to be a savings. And it wasn't randomized. So in other words, there were probably we might have gotten some patients that were going to naturally have a reduced utilization, and we maybe avoided some others who said no, who were going to maybe be heavier utilizers, and that we would not have had an effective program with. But we took this as good news and reason to continue. So our next steps, as Bridget mentioned, we certainly want to take care of sick patients, and we want to use our office teams that exist in the office to take care of patients who are less sick. Let our medical home, the usual structures there of the physician, the staff in the office, to help us manage people's both self-management needs when we can, and coordinating their care. But for the sicker patients, we do think that the care manager offers a good resource. And so we want them to engage. And to get them to engage, we do think that the story of the face-to-face was really important. So we're trying it on at one office. And we're going to use a technique that our hospitals engaged in pursuing across the system, which is value stream analysis. And it's kind of like using a Lean Six Sigma technique to figure out what are all the steps involved. And that's that little picture. We actually have to have stickies that say, what are all the processes, who are all the people, and then are there things that are actually things that one person can do, or are there things that are unnecessary here? So we're going through that process now. And our goal is to assist the highest risk patients with a face-to-face visit on certain days of the week when we can offer that. When we can't, we have to figure out what to do. And then address some of the high-risk care gaps that might exist, whether those are also seeing those who aren't on statins, aren't taking an aspirin. And then evaluate the need. Maybe we can reorganize some of the people that are in the office to help provide that support when the care manager isn't there. So for some face-to-face opportunities to help people engage with their care manager. So that's what we're currently doing. I'm also going to talk to you about our efforts to look at some population management efforts. And so we have another quiz for you. So Actually, I got this question after reading JAMA a couple weeks ago. There was an article that was giving a preview on CMS's new value-based prevention project. And actually, it was kind of fortuitous to have seen Ashby Wolf here from the last meeting. She's a former graduate of our program and a friend, and I said, I'm going to call Ashby and ask her about this. So we talked, and here's a question. So see which of these do you think that CMS will be paying for? So are they going to pay us to provide, to collect blood glucose log information? Number one. Are they going to start paying for over-the-counter payment for nicotine gum? Are they going to pay providers for making sure that we give Atacel injections or booster on people's TDAP? Are they going to pay patients, I should say, to track their activity using like a Fitbit? Or last, will they pay a sliding scale payment for reducing cardiac risk across the provider's entire panel? Let's see what people say. I don't think I write hard test questions. There we go. We got a little bit of a spread there. It would be great if they paid us for all the work we have to do to get patients strips when they need it, but I haven't agreed to do that yet. It would be great if there were more benefits for nicotine replacement. But that hasn't been on the table either. We should be giving, not necessarily by that schedule, but we should give our patients Atacel boosters, and that's a completely different issue. And it would be great if we were able to find ways to incentivize patients for exercise. And we're looking at that in a research project, actually, right now. But the last is the answer. And I can tell you a little bit about that program. It's the Million Hearts Cardiovascular Disease Risk Reduction Model. It's a very cool idea. And it's starting as a research project by CMS or a pilot that they want to gather data on. And then, based on the results, they would expand it. Each patient who's in this, who would be a beneficiary in this pilot would be, their physician would give them a 10-year risk score based on the AHA calculator. And then there would be a focus on the high-risk patients, people who have a risk of 30% or greater. And the rewards that they would be paying, or the payments, would not necessarily be based on just a specific blood pressure or a cholesterol target, although that would be part of it. It's really how do you lower their risk. And the payment would be made by how much you've lowered the risk. So for each patient who you reduce their risk by more than 10%, you would get $10 per month. For each patient who you reduce their risk from 2 to 10%, you would get $5. And if you did reduce somebody's risk by less than 2%, there would be no payment for that. But in aggregate, if you look at that across the whole population and you had a good system for doing this, it could provide significant resource. And this is one of the slides that Ashby sent me. And it was kind of like an assumption model. So for a small practice with 4 to 5 providers, and 400 Medicare beneficiaries, 50 high-risk patients might fall out of the analysis. And for those 50 people, if you were able to help them get that 10% risk reduction, they're saying that initial point is when you do your initial evaluation. And you just get money for doing it for those patients at that time. So just for your initial one, you do some shared decision-making, show them some resources, and then maybe in your first measurement piece, you might not have moved the needle yet, but then each subsequent month after moving the needle, you would get payment that aggregates to those 50 beneficiaries that you're helping. So it could be a model to help support the care team to be able to do that intervention. So we kind of have talked about this, and we've actually started something. We don't know where this will go. There's 720 practices that will either be in the control group or an active management group, and we're looking into that. So is actually the UC Systems looking at it, but they want to get a mix of practices, so who knows if what they'll actually be looking for. But we're going to try this within care management. Since we have people every day working with patients, looking at the charts and interacting, we'd like to call this our bundle. And I know that some of the other groups who have come and spoken here talked about their diabetes bundles, and I've heard of other groups with their cardiovascular bundles. And if you follow we are going to try to say this is our Million Hearts bundle, and it would be: are they on an antiplatelet therapy, or if there is no contraindication? Is their blood pressure less than 140/90? Is their cholesterol 100, or are they taking a statin? Is it less than 100, are they taking a statin? And are they smoke-free? And if the answer is all yes, well then they met your bundle. So we looked at our current patients in care coordination, and about 43% have achieved the bundle. So we have some work to do. And we've probably made some changes for patients, but when we focus on it like this, what can we change? So we've set a stretch goal for ourselves to reach 90% of this group of patients by September 30th. And we're going to learn from it. We're going to see what we need to do. It will certainly be, our pharmacists have worked on similar type projects, and we're going to see what we're able to achieve. If we don't achieve the stretch, we'll figure out what we did wrong and go back to the drawing board. So we think it'll be a good way of practicing for this, and certainly in the future, if it does become a model of payment, it'll be a way that we can support the resource.
So, on that, the only one that's really kind of self-reported you could budget is the smoking tobacco-free. The rest of them you can get out of your own system of EMR. Is it calculated independently?
For which one, I'm sorry?
I mean, the physicians aren't doing this calculation, right?
No, we would be able to, we would actually do it through our own audit process.
Yeah.
And I think I don't know what Medicare is going to do for the smoking. I have no idea.
Yeah.
It may be a part of the new claim, like a G code. So our next steps are to help us, and I'm almost out of time, to help us segment our population. As we've been looking, there's certainly the issue that we want to make sure that the right resource is paired with the right patients. And we have a great program that we've had through managed care to manage our patients who have kind of catastrophic and high utilization, and through intensive case management. Our care management may be able to help build when patients have just come out of kind of basic bread and butter hospitalizations, and they have chronic disease that is causing some of their complications. And then the next level down, there's patients with chronic disease who are not well controlled but haven't had failing function yet. And lastly, then, the group that is prevention and wellness. This is sort of everybody, but what resources in each level, and how can we track the number of patients in each level and make sure that there's adequate staffing through our medical homes and the support for our medical homes to help each population. And that, in aggregate, is our entire population. So one of the next steps for us is to help us look at the office roles. We have our whole ambulatory operations looking at what we can do for pre-visit planning, what we might do for better panel management, and increasing our use of pharmacists to help us achieve some of these targets. Lastly, it's, Alan, you were referencing it, our physician dashboard that we were talking about, and monthly quality reports, being able to put information on how often we're doing our smoking cessation counseling, or even when we're doing it, making sure that we document it. And then last, really trying to grow our appropriate use of statins, and UCOP, the UCs are focusing on this as a potential area that we can learn from each other, and we've started to take a look at comparing our numbers for patients who have CAD or on a statin. So our conclusions, we're going to try and keep continuing to change our system. It certainly, it takes a change to be able to deliver better population health. Technology, as Bridget mentioned, there's opportunities to support self-management in a way that is that doesn't lose kind of what methods people like in terms of face-to-face, but offer them some other new options. Care managers really offer us an opportunity to share the work as physicians and to avoid physician burnout, because we didn't talk about it, but we have found some